Hello, everybody. Good morning, good afternoon, and good evening, in the words of the good Dr. Tedros, World Health Organization. Welcome to another great episode of Coding with Christine Hall. So, we've been away for a few weeks. We had a lot of interesting things happen during the time. I got a little older. Don't judge. We also had a series of hurricanes that passed through the great state of Florida where I live. And we did fine, by the way. We really did. We were a little caught off guard by some of the tornadoes, but full disclosure, we're not really tornado people. We're more hurricane people. So, where we are very prepared for hurricanes, we were not prepared for the tornadoes. But we here at Stirling Global Solutions are all okay. We're doing well. And we're super excited to have you all back with us today. Great to see you guys too on our national tavern style pizza day. Had a great opportunity to spend some time with my good friends Pam Vanderbilt and Sonal Patel and Gabby. Gabby, what is Gabby's last name? She's going to kill me that I don't know it off the top of my head. We just know her as Gabby. We spent some great time eating tavern style pizza in Las Vegas this past week at the AMBA, the American Medical Billing Association's annual conference. We had an absolute amazing time, had a lot of wonderful speakers. My personal favorites were Shannon DeConda and Robert Lyles was another great speaker that we had. We heard from our friends Brenda Edwards. We heard from our friends Beth Schleeper and Ashley Morgan, who is always one of my big favorites. And a lot of other great speakers were there. Hopefully next year we'll be able to see you there too. Today is also National Make a Dog's Day. And you know, I absolutely live to make Toby Hall's day, don't I, darling? Yes, I live to serve him. So we will be honoring him today as well. So let's cut to the chase. What we're really interested in hearing about are what are the new codes that are presented to us this year. So we are 22 days into our new ICD-10 codes, and we had a few changes, not as many changes as we have seen in the past. So we had 36 deletions, 13 revisions, 252 additions for a total of 74,260 ICD-10 codes for 2025. So that number just keeps growing and growing as, of course, with new technology and with developments in different types of conditions, knowing more about comorbidities and manifestations, we're going to have more codes that are added to provide us with that clear specificity. You know, that's really the point of the reporting our diagnosis, is that we can report them to the highest level of specificity. It makes for good continuity of care. It makes for good protection in litigation. And it also supports payment for the services that we're providing to our patients. So a lot of great changes there. Now, I will tell you, not a lot of actual guideline changes. Now, we're all friends, and you know that I'm fascinated by the guidelines, right? I love to know what are the rules? How do I follow them? Right? Where do we get to the positive outcome? So I always read my guidelines every year, and I find that, you know, when we're anticipating changes, that's the best time to see any new changes that may have been added, but also to reiterate what we already know. So I read those guidelines annually. And, you know, I don't know about you, but every year I learned something new that maybe I missed last year, right? So always a great idea to sit down once a year and go over those great guidelines. Now, one of the things that we did see tremendously was an increase to tabular instructions. And that's something that I've seen over the last few years as we really become more and more comfortable with ICD-10, is that those tabular instruction guidances have changed or they have developed. So we see a lot of things right now that we're moving excludes ones into excludes twos. Remember, excludes one mean it's either or. It's either the primary code that we're looking at or the code listed under excludes, but never both. Kind of like saying you were born with something or you developed it later in life. Well, were you either born with it or did you develop it later in life? Can't have it both ways. So a lot of the excludes one that were hard ors have now been moved into excludes two, meaning that that primary diagnosis doesn't automatically mean that the excludes two is covered by that primary diagnosis. But if that patient has both conditions, you should report both of them. So that's where that excludes two. So we are seeing that before we had hard stops at excludes one, and now we're really starting to embrace that sometimes exclude one codes do exist and are better represented as excludes two. Also, we have continued to expand our guidances for those code first or use additional codes if applicable. So where the rule is, if we know what the causation is, that we sometimes code it first or we use it as an additional code, the if applicable has been added for some of us that are very literal. And what if you don't know? How do you move that into play, right? Another thing is the tabular instructions have also added a bit of examples. So you're going to see that they've added add an additional code if applicable, such as, and they give examples. Now remember, such as is simply just saying that these are like types of conditions that could or often are present in addition to, but it could expand beyond that. So such as is not limiting, but it's more of an inclusive term. So they're giving us examples such as, but remember that we're all very unique. And sometimes we're going to have other situations that present themselves. Now, lots of new codes have been added, and some of the highlighted areas that I really wanted to talk about were Chapter 2, Neoplasms. Huge expansion. 63 new codes expanded into our neoplasms, primarily to identify lymphomas that are in remission. So the ICD-10 committee that coordinates and maintenance committee, they've been meeting they do meet quarterly. And in many of the quarterly meetings, we have had representation by the Alliance of Dedicated Cancer Centers. And they explained that not having a code for lymphoma in remission has made it really hard to compare and to evaluate patients' care, because these useful statistics, they help us track resources that have been used and to show the accurate outcome and for those different types of lymphoma cases. So you'll notice that those new codes for in remission, that they have been added to kind of assist our oncologists to report when the patient is actually in that remission status. And then usually the guidance is if you've been in remission for up to 5 years, then you move into a history of kind of mentality there. So again, these codes were essential for oncologists to properly report and to help, check on those patients that are in remission for lymphoma, maybe if they're needing scans or if they're needing some post-treatment follow-up, these would be the most appropriate codes. Also, for oncologists, they've added the codes for the primary central nervous system lymphomas, or the PCNSL. And that's a rare type of non-Hodgkin's lymphoma. It starts in the spinal cord, in the brain, in the meninges. And we had a code for it in ICD-9, but it disappeared when we converted over to ICD-10. And so a lot of providers were having to use a non-specific code for that malignant neoplasm of the brain. And it's just nice to have that code back so that we can accurately report that patient's current neoplasm situation there. So a lot of new changes that have happened in that particular area. Now, another area that I wanted to show you was we received some new codes in the endocrine system this year. primarily when it comes to asymptomatic type 1 diabetes, as well as identifying the different levels of hypoglycemia. So that was a really big one. New codes for low blood sugar, hypoglycemia, they were needed because doctors and different types of healthcare providers, they needed a way to more accurately describe the severity of the condition. So before these new codes, it was really hard to tell the difference when a patient had mild or moderate or severe cases of hypoglycemia. And it made it difficult to track and to compare how often they had to how these patients were presenting with low blood sugars in different types of events, or those patients that were on sliding scales for medication management, to really see when they were having to adjust those scales. Betty, I love you. Thank you. Betty has helped us out with some of those committee information where the details are really important. Thank you so much, Betty. It takes a village, guys. I just had this conversation that the key to being successful in this industry really has to do with the networking, who you know, and we want to know everybody. So please, if this is the first time you're joining the podcast, make sure that you are connecting with myself and you're connecting with the other guests that are on the podcast today, whether you're live or whether you're on demand. We want to get to know you. We want to be part of your network, your team, your village, right? So we also had some codes that were added for obesity as a long-term condition. So they've added new obesity codes to kind of classify obesity instead of having to use other obesity. It's important to remember that obesity classes are often determined differently for children based on their percentiles, as opposed to the adults that we use a BMI inclusive type of reporting method there. The 2025 updates for ICD-10 also added some new details and changes on how eating disorders are classified. And my understanding is that they did this to align better with the DSM-5. So these updates, they really do improve how we diagnose disorders. So these new codes, they're adding specificity, the type and the severity of the eating disorder. So it's going to allow for a wider range of conditions to be covered. And these changes, they aim to improve how doctors report or even treat some of these very critical eating disorders. We haven't seen that in a really long time. So I was excited to see that big change there. Another area that we saw changes to were in the circulatory system, or diseases of the circulatory system. So a couple of new codes that were added for cement or fat embolisms of a pulmonary artery. So when we talk about pulmonary cement embolisms, or PCEs, it's usually a complication that occurs when cement leaks into the pulmonary arteries after a vertebroplasty procedure. It's very, very common procedure. They're injecting in cement into certain vertebrae to provide some stability for fractures, whether compression fracture or traumatic fractures. Alternatively, you could also have a fat embolism, and this is into that pulmonary artery, and sometimes those embolisms can cause a cor pulmonale. And it's a condition where this occurs when fat globules, they enter the pulmonary circulation, and it causes that pulmonary system to have an embolism. And sometimes this happens when we have a long bone fracture, or when we're doing bone grafting, we might see this type of fat embolism happening in the pulmonary arteries. So we did need some more specific codes to properly represent those types of embolisms there. Another area that we saw a huge amount of change is in the digestive system. So we have new codes that have been added to further specify the different types of fistulas that we could have, whether in the rectum, the anus, or the rectal anal cavity there. So they've added 5th and 6th characters there to provide more details on the complexity of the conditions there. Another area that we saw some changes, and a lot of changes. So all in all, we had 33 new codes that were added into the musculoskeletal system and connective tissue. One thing that we also want to consider when we hear those numbers, like, wow, 33 more codes, remember musculoskeletal is always very heavy with laterality. So there's separate codes for the left, the right, bilateral, unspecified. So when we add a new condition, we usually add 4 codes to cover all of the different lateralities that may be present. And this section was no different. So in this section, on the intervertebral disc degenerations, so your codes, your M15 codes, we now provide additional code detail for either the lumbar or the lumbosacral region. So pain specifically added for back pain when the pain is limited to just the back. For cases where the pain radiates down the leg, like sciatica, for codes that represent both the back and the leg pain, where both areas are effective. And then not specific pain location, where the documentation just is not specific enough to identify where is that pain coming from. So we also had some diagnosis codes for our synovitis and our tenosynovitis. They expanded those out with 24 codes to identify the different body parts. So these changes were elaborated in the section there. So when you were looking at chapter 13, musculoskeletal, we want to make sure that now we have the ability to be extremely specific. Fun fact, I was doing a presentation not too long ago, and I wanted to discuss some codes that maybe are limited and we may have to repeat. So for example, my mind went to, I've got 10 fingers, 10 toes. I wonder if there is a code that would be specific for which finger or which toe was fractured. And honestly, I had a hard time finding generic codes because of the amount of codes that have been expanded in musculoskeletal. I mean, we're able to identify specific codes for each digit. We're able to specify whether a fracture, even in a long bone, was more distal or more proximal. So really focusing on the where. And I was pretty impressed of how much musculoskeletal has grown in specificity. So those of you that are working in orthopedics, make sure that you're revisiting your codes. You know, go away from those resource tools that maybe are limited to unspecified or maybe, you know, unspecified codes, and really expand out. Challenge yourself to make sure that you are adding additional codes to those specific areas. Now, just to give my own little tidbit, one of the things that I've been most passionate about this year are the external cause codes. So some of you may have noticed on our YouTube channel over the holidays last year, we wrote the night before Christmas in ICD-10 codes. If you haven't seen it, you've got to go to the YouTube channel and you've got to take a look at it. Some of these codes really had us laughing for a while. But one thing that really dawned on me was those external cause codes, while they're not required to be used, the story that they tell oftentimes helps us promote our claims getting paid in a more quickly matter. Remember that the claim is the only way that we talk to a payer. And so if there is an injury, if I'm a payer and there is a slight chance that somebody else might have to pay this bill because it's an injury, maybe it's an auto accident injury or a workers' comp injury, but the claim only says injury. As a payer, I might delay that claim and ask for additional documentation. Maybe I even deny the claim for coordination of benefits. But if I use external cause codes explaining that this particular injury happened as a result of tripping over Toby Hall when I was trying to find the restroom in the middle of the night, then the payer automatically knows that this is not an auto accident and not a workers' compensation claim. And so I find that I receive less requests for documentation when I add some of those external cause codes to further explain how the injury happened, eliminating the option of coordination of benefits. The other thing, those external cause codes have been very successful at supporting a level of E&M. Now, hear me out, guys. We don't really use external cause codes ever as a primary diagnosis code. But think about the provider that's maybe doing psychotherapy and the patient has been progressing well. However, they had an event happen in their life. Maybe their cat passed away and that has now triggered them or it has regressed them. And at this particular visit, we're going to see the patient for a longer period of time than we would have because of this special circumstance. Or we're reporting that the depression has now increased from a mild to a moderate, but that external cause code of the cat passing away, that might be the extra information that the payer needs to understand why there was a change in diagnosis and why there was maybe an increase of time that was needed on today's encounter. So again, while they're not necessary, they have a significant purpose, and that's really to paint the medical picture, as my good friend Sonal Patel always says, right? So we want to make sure that we're utilizing all the codes that are out there and available. Now, another area that I absolutely love are all of our Chapter 21 codes. Those are the codes for our encounters or for additional reasons that might be relevant to the patient's visit today. Remember, from our perspective as coders and billers and auditors, we're really looking at the claim from a today perspective, or the progress note from a today perspective. What happened today that we need to add a code or a diagnosis to explain what happened at today's encounter? Those of you that know me, you know today is my word. What's going on today? And so when we're looking at visits, we do want to explain everything that impacted today. Now, one of the other areas that has increased over time is the area of genetic medicine. And new genetic susceptibility codes were added this year. Susceptibility to epilepsy, to neurodevelopmental disorders, even susceptibility genetically to obesity. You know, I have really good friends of mine that have struggled with obesity for a very long time, but looking at their family portraits, you know, mom also struggled, grandma also struggled, Aunt Ruth also struggled, Aunt Mary also struggled. And this really is more of a genetic struggle than it is an individual struggle. And it's nice now that we've got additional codes to really reflect that condition appropriately. So Chapter 21 includes a new code for genetic susceptibility to obesity. Imagine if we start to look at it a little bit different. Tabular instructions to add additional codes for related disorders and manifestations. And we've also continued to embrace the social determinants of health codes, specifically for those patients that have insufficient health insurance coverage. So this is not that they don't have any health insurance coverage, but maybe they have a very large deductible, or maybe they have a very restrictive HMO, which is not going to allow them, or their benefit package does not allow them. So for example, I have a connective tissue disorder. And so it's very beneficial for me to get massages on a regular basis. I know, right? Christine needs massages. No, but more from a therapeutic position, more from like the physical therapy type of perspective. However, I have physical therapy benefits under my insurance, but they exclude massage. So that's one of those areas that I have to come out of pocket. And because my health insurance doesn't pay for it, there are times I make the decision not to get that therapeutic massage because I don't have 50, 75, 100 bucks this week to take care of my physical requirements because I like to eat, right? So it's good when today I should have had that therapeutic intervention, but because of insufficient health insurance coverage, that I have decided not to. And it is considered a social determinant of health. We have patients out there that have insufficient welfare status. And when I think of this code, I think of those patients that maybe they're on Medicaid, but maybe they're on a share of cost or a spend down program where they have to acquire a certain amount of the healthcare responsibilities for a period of time. In Florida, it's per month. In other states, I've seen it for 2 months. I've seen it up to 6 months of that spend down or that share of cost. And when, oh, technical issues, Kimberly, I think that's on your end, love. I think we're good. But when we talk about that spend down process, a lot of people elect to not go to the doctor or not to pick up those meds or not to get that therapeutic intervention or diagnostic intervention because they cannot meet the spend down or they cannot meet that share of cost this month. And the best way that we can make any effective change or that we can properly represent that social determinant of health is to once again add those specific codes today as it's affecting us today, right? So I do see some questions that are coming in through the chat box. This is one of those areas that I do want to address any questions that you might have. Maybe you want to know, hey, Christine, what are those 4 circulatory codes that you were talking about? Or, hey, can you give us a better example of such as, or if applicable? So let's look through some of these questions here and let's see where we can clarify some of these issues. Okay, I have a question that is here from Mary. Hey, Mary, how are you, my friend? Good to see you. So chapters 14, 15, and 16 did not have any updates this year, thankfully. But, we always do want to go in and look at those tabular instructions. So while there were no added, no revised, no deleted codes from those 3 chapters, we do need to make sure that any type of tabular guidance, and tabular guidance has been changing tremendously over the past few years. Like I said earlier, those exclude 1s are now finding themselves moving to excludes 2. And I don't know if you guys got the note. United Healthcare came out early in the year and said that by May of this year, 2024, if an excludes 1 code is added to a claim with a primary code, that will cause an automatic denial. Well, when these exclude 1s shift from exclude 1 to excludes 2, then that would open up that area and we really could have patients that present with multiple problems that are not inclusive of that original base code and now have moved into an excludes 2 where we can and should report those as well. So while there's no changes in some of those categories, please make sure that you still are taking time to review your tabular guidance, at least for the top 25 codes that your practice traditionally reports. Go through and see if any of those tabular instructions have changed for you. And that might make a difference in how you report your future claims. We're 22 days into it, so now is the best time for us to start new habits, right? To make sure that we are doing things the right way. So we are at time again, my friends. I do want to ask you, if you're enjoying these podcasts, make sure you're going to YouTube and you're subscribing. They'll just notify you when a new episode has dropped. You won't get bombarded. Also, please make sure that you're going to our website and you're joining our newsletter. Newsletter always comes out once a month, and it has some of the highlights of the changes that we can expect in the industry. I always try to make sure that I'm sharing with you any great tidbits that I'm hearing from the payers or any new guidance. Remember, next month, we're anticipating the Medicare final rule to drop, and we're really going to want to make sure that we are up to date on all those changes that we're expecting. Starting January 1st, we'll be reporting new codes for telehealth. We'll be reporting new guidances. We're still on the fence whether or not we're going to have some of those liberties from the public health emergency extended into 2025. So keep an eye out, sign up for the newsletter. I'll keep you posted as soon as I get that new information. Make sure you're following us on social media so that you can be up to date in all that wonderful information as well. Make sure you support your dogs today and have that tavern pizza for lunch. It's great seeing you guys again. Take care.
Thanks for watching.